Welcome. It's a delight to be here again and to learn more about nursing. I think I deserve a continuing education credit. This is my fifth. Come on, Ann, what are you laughing at? You taught me a lot. It's a delight to be here with Mimi and to have her family here, including the little children who you saw in that picture who are in this. Yes. Raise your hands. Come on.
Go ahead.
Show them how big you got. Who are a fine young man and a fine young woman, as I understand, also a nurse. Let's begin this way, Mimi. What got you into the business of introducing mothers to their babies and vice versa, as opposed to any other thing you could have done in nursing? Why did you choose that?
I went to Northeastern undergraduate, and I did.
It's okay.
I know.
Is that a Northeastern
Sure.
grad over there? Yeah.
And I did the cooperative education. And I did a co-op out on an Indian reservation in Tuba City, Arizona, with mothers and babies, and just really could see what the difference that you could make, learning about different populations, learning about birth practices. So when I graduated, I was fortunate enough to land a job in Stoneham at New England Memorial Hospital. And I have to say that was probably the best nursing leader that I got to experience in my career. Ann Benson was a nurse. I think she might be a BC grad too, but she probably for sure. But she was that innovative manager, leader before her time. She gave new grads the opportunity, had the mother-baby model of care before it was popular. But also she took those new young nurses, gave them a wonderful precepted experience when other hospitals weren't doing that, and supported and encouraged them to get involved and to do different projects. So I went right from school to OB, and I haven't looked back. It really is about helping moms and families, because it isn't just the mother and the baby. You're really setting the stage for them, and it means so much. There's a researcher, Penny Simpkins, who talks about mothers' long-term memories of their birth experience. And years from now, if their kids are my kids' age, they still remember their birth experience. So we have a unique opportunity to play a role and to influence the family's health and outcomes.
That's right. You talked, when we interviewed you earlier, you talked about being in a grocery store or something, and some mom will say to her 6-year-old, that's the nurse, and the 6-year-old, can we get some candy or something?
I know, we always laugh. They'll say, do you remember me? And I'm like, I think you had a little bit more weight back then, You've lost weight.
But what you say is ironically true and quite wonderful. I mean, I have 3 kids, and I was present at their births because, this is the years in which we had our kids were the years in which that was happening. And I remember the medical people, and I can't imagine they remember me. But I remember them, and that must be highly rewarding to know that thousands, I imagine, of women in particular, not the babies, but women in particular do remember you for your wisdom, your kindness, your short temper, whatever you exhibited that day.
Hopefully calmness.
Let me ask you this, you do something that is, you witness to a miracle. Or you do when you're in that delivery room and so on. Does it ever get to where it doesn't feel like a miracle anymore?
Absolutely not.
Never?
Every birth is different. Yes, you've been there for many births, but it's so special and unique to that family that it's not about what I've seen and what I can do. It's really about their experience. And even if it's their third baby, to get the joy and the love of adding to their family. So it is really an honor and privilege, as I said, to be there. And every birth is different, and every experience is different. It's very rewarding.
You talked in the film clip, the video clip, about the okay nurse versus the nurse. I don't want to abuse people who do good work. Okay, nurses are fine with me when I need care. But what's the distinction you draw between the okay nurse and the nurse you want to be? Or you want your nurses, the ones you teach these days, to be?
Right. I think that it is so important for us to look at what we do and find ways to improve. Things that we did many years ago, maybe we thought we were doing the best thing, but when we reflect back or we do research and we look to say, we really haven't made those outcomes that we thought that we would. There comes a point when you have a large volume of people caring for patients coming in and out. And as everybody knows, there's some nurses that really touch you and keep that patient-centeredness. And then there's other nurses that come in, they do their job, they know their medicines, but they just are there coming back and forth. So being an okay nurse to me means, getting the right medications, practicing safely. But what's really, I think, the beauty of nursing is that relationship with patients, getting to know patients and being there for them and helping them. And then you could feel good about what it is that you are doing for them and setting them on that path.
Yeah, it strikes me, I was a journalist for many years, and after I interviewed people, I really didn't care whether I ever saw them again. There was no, quite honestly, it was a job. There was no intimacy. You are engaged, and I presume many people in this room are engaged not just in OB/GYN, but in other things, in the most intimate kind of relationship with people who otherwise would be total strangers to you. And they're just revealed, naked literally, naked emotionally. Mm-hmm. Is it hard to move in and out of that? Is that draining for you in particular? Can you be close to a person and know they're going to leave the facility in 3 days and you'll never see them again? You may get a nice card at the first birthday with a little picture of something. Is it hard to go from a position of intimacy to a position of never seeing this person again, really? It's a temporary intimacy. That's why I'm asking.
It is definitely a temporary intimacy, but I think that you see them for a few days, you think about them. Certainly there's some experiences you have in some families that you might not remember the name and the exact details, but you remember them. And the one thing about birth is people often have more than one, so it's really nice to see them. Yeah, and they get so excited. Oh, you were our nurse the first time. Yeah. We're in the same room. Yeah. It's wonderful to be able to do that. And it is intimacy that you have that shift. And I think, again, what you had chatted about, the difference of separating. And sometimes for nursing, it is very difficult. I think I was telling Ben earlier, and many nurses, whether you're in OB or other fields, I'm sure that you care for your patients, and then you give report, and you're going to be off for a day or two. You go home, you go to sleep, and then you wake up at 2. Uh-oh. Did I do this? Did I tell that? Or even, I wonder how she did. Did she deliver? Did everything, go okay? And you can't help but think about your patients. I often love getting those pictures from patients later because to me it validates that things are going well for them. And those first 2 weeks at home for new moms are miserable, but to know that they've gotten through it and that maybe we've helped them is very rewarding.
Yeah. Let's talk about something you raised earlier, just a few minutes ago. You talked about practices that you assume are the right thing because people have been doing them forever. Mm-hmm. And give me an example of something like that where you looked at research and you said, or you and colleagues looked at research and said, this is not really, we're not getting good outcomes out of this the way we thought we were 20 years ago. Yeah. So what's an example of that?
Well, I can speak to first my experience and my research here at BC.
Sure.
I had been a labor and delivery nurse for many years. And I've gotten over those first couple of years where you're learning something and you're comfortable, and I felt I could go in and take care of a patient without any problem. And one of the things that I do like about nursing is that camaraderie, that you have your coworkers to work with you, to support you. When things go not so well, they're there to pitch in to help you. So it's wonderful to have that camaraderie, but sometimes, and what I found when I spoke to that in the video, is that the literature said nurses didn't provide great labor support. And I went, what? you know, the two faculty members who were the OB was Joellen Hawkins and Maggie Carney.
Right.
And they told us, okay, question, what is it that you do? I said, well, I provide support to women in labor. That's what I do. Well, of course, they don't stop there. What's support? What's this? Look more. What is all that? So when I delved into the research, and the research was saying, we don't provide well support. Thinking about nurses might have been more concerned with getting that IV in, being the best at fetal monitoring. I had to sit back and say, do I provide that care that patients need? Am I so concerned about what the monitor's saying? Am I present at that bedside with that patient and involved with them? So that's certainly one example. Mm-hmm. The other thing is we laugh about it if you're not an OB person, and my children, my daughter's okay with it. My son says, Mom, people don't talk about these things normally,
okay.
especially when he was an adolescent.
Young man. Your mother's about to talk about
But about breastfeeding, our knowledge that I taught people, breastfeed for 3 to 5 minutes on the first side and then increase it. And we think that it's going to prevent sore nipples and promote breastfeeding. Well, lo and behold, it really undermined breastfeeding, and we were causing harm. So we had to really think about what is it that we do and what is the best to prevent sore nipples is correct positioning, having the nurse there with them and getting that together. So there's so many things that, and it's just such an exciting time for nursing that we are questioning what we do and can we do it better, what it is. I'm very happy to be a nurse now.
Talk about something that you're involved with A1, if you would, and that is making sure that women know the best thing to do is to be full term.
Yeah.
And what's the phrase you used?
Go the full 40.
Go the full 40,
Go the
right.
full
Exactly.
40.
Sounds like a football instruction.
I know.
Go the full 40. And how did this develop? I mean, when we were having children, having an appointment cesarean when the baby was considered close enough was not unusual, and I know from staff in my office, younger people in my office, it's not unusual now. So what did you learn, and how does A1 go about expressing this among in the profession?
So A1, like other specialty professional organizations, helps to set the standards and the guidelines. They provide education materials, best practice guidelines to help nurses do a better job for the patient at the bedside. And when you speak about go the full 40, what we were finding, and many nurses in labor and delivery units were finding, is that people were getting tired. And I think it was probably in the late, maybe about 8-10 years ago, it was, scheduling. Mm-hmm. Society, people wanted to have their babies at the same time, whether it be healthcare decisions, but we were deciding we were getting used to technology. We were good at it. We could give them some medication to make somebody go into labor, and we thought, well, that would be better. But as we looked at that, one of the consequences were babies were being born a little early. And some people would argue, well, what's a little early? Isn't that okay? 2 weeks early, 3 weeks early, that's close enough, isn't it? And what we were finding is close enough wasn't enough. And that it is really important for women to go into labor on their own, so spontaneous labor. And so we had chatted at one point about the changes in obstetrical care. Like many years ago, it was at home, moving into the hospital, and the issue of hospitalization and medicalization of birth. And we were doing ritualistic care and thinking that we were making difference. Mm-hmm. Some of the stuff was helpful, some of it not so helpful. Certainly our advances in our neonatal care is fabulous. A lot of technology is great, but when it's too far in an overuse situation of technology, then we sort of make some of those problems. So I think that going the full 40 was something that we might have influenced in terms of using our medicines and our technology to sort of push the issue. And it was now us trying to educate consumers back that going the full 40 is better for moms, better for babies. spontaneous labor, and with that, A1 has also instituted the care of the newborn, the late preterm infant as well. So Going the Full 40 is a campaign for nurses to learn about best practices to help outcomes. It is also a campaign for consumers to teach moms to say to your provider, no, I don't need to be induced. Let's go into labor on its own for the betterment of the baby.
Where do the doctors fit into this? Are they supportive of this? And so on?
You know, it is wonderful, and I said that's another exciting thing about being in nursing now. Many years ago, it might have been us against them, and now we're seeing a lot more teamwork, that it is important for us to collaborate, to work together, to have the same message. So our physician partners have, set guidelines that not to induce women before 39 completed weeks. And they're advocating our Go the Full 40 as well in spontaneous labor. A1 and ACOG and the midwife.
You've got a lot of acronyms in your profession.
Yes,
you
we
know
do.
That? I hear some
A1.
knowing laughter from other nurses.
ACOG is the American College of Obstetricians and Gynecologists, our medical partners, and A1 is the nursing organization.
And don't you have an acronym, CARING or something, for which you can't
do.
always remember what it means? It's our
I
own
remember.
organization.
So the organization A1, the Association of Women's Health, Obstetric, and Neonatal Nurses, is about promoting excellence in nursing practice to improve the maternal and newborn outcomes. And we do that through caring, which is a commitment and accountability to professional practice, accountability for your actions and the actions of our nurse, research, right, integrity, and I always forget that.
Who's got the answer out
Kate
there?
does, I know. And diversity as well as generation of knowledge. So A1 is involved with advocacy work to setting standards, promoting research and funding research, and generating, working together. We're talking about working together with our other partners to set the standards. One of the newer things that we're working on right now is the measurement. So we say that we want to provide great care, and that's well and good. But how do you know? So they're looking, and with our other partners, looking at what are the measurement, the perinatal quality measurement that we can use to measure and to say that, yes, indeed, this is the care. So it is a huge effort. And it involves government agencies in terms of CMS looking at that, as well as our Joint Commission who accreditates hospitals, looking at what are the core measures, how do you define what quality care is? And who best to define what quality care is than nurses and the professional organization that are setting the standards. Physicians as well,
Sure.
and lactation consultants who are helping with breastfeeding. So we need to work together to identify those.
Well, can you help me with a term you used in your interview called informed caring, which is the way you characterize nursing, or at least nursing the way you want to do it. I know it's not your term, it's somebody else's.
It is a mid-level nursing theorist who in nursing school we all go, oh, theories, but I think that it is something that for me, and I learned of it in my graduate program, and it speaks to me. It is what makes me feel about what it is that we do. So Kristen Swanson's theory of informed caring is about, they'll say there's 5 processes, okay? Knowing your patient.
Start taking notes, everybody.
Knowing your patient, being with them. And for me, that really resonated that I had to be present in the birthing room with them, not at the desk in doing the fetal monitor. So being with them, enabling them, okay? Helping them do what they needed to do, doing for things that they couldn't do, giving a cool cloth for comfort, helping them change positions, educating them, telling them what they can expect. And then the final one is just it's maintaining belief. And for me, an OB, it's about helping them see that it's not about just what we're doing and that I can handle or bathe their baby more efficiently than they can, which they always feel, but giving them that belief that it is about them and that they can do it and they can leave the hospital and care for their baby.
Yeah, can you tell the story you told me about the woman who was having trouble starting to breastfeed, or the baby was not interested, essentially, and it's a kind of informed caring that's a little duplicitous and clever, and but tell that story, because it's what you were just addressing now. Not, I know how to do it, but it's about you. It doesn't matter how well I bathe the baby or know how to deal with lactation. It's whether you know it counts.
It's certainly. So breastfeeding is certainly by research has shown to be the best food for babies and for moms, but it isn't always easy. And as nurses, again, this is an area that maybe we weren't very good at promoting, and that in fact sometimes we may have undermined the success of breastfeeding for moms. So there is a big push for us to be what we call baby friendly and help support breastfeeding and no formula and helping moms breastfeed successfully. And you know, the first few days in a hospital is sometimes babies don't nurse right away, or they have difficulty. Sometimes it's due to the birth experience, the medication, being a little bit early or whatever, that we kind of will sit back and give babies a little time to do it on their own. So the first 24 hours, if the baby doesn't nurse so well, we say, no big deal, just do skin to skin. Then after 24 hours, if this kid isn't eating, we start to say, okay, what are we going to do here? But the evidence in baby friendly is no formula. So we get the mother to try to pump. She gets nothing. We say, okay, try some hand expressing.
This is very disheartening.
It's so hard for them. So this particular mom, she had gone her 24 hours. She had the night shift. I was coming in the morning, and it was probably getting to be about 30 hours. This kid needed to eat. She was getting ready to go home and have never breastfed her baby successfully. And the baby would get to breast and just go, do nothing. I'm like, come on, kid. So we sat down and said, all right, here are your options, Mom and Dad. Dad was there too. He was doing some skin to skin as well. But just saying, what is it that you want to do, okay? Is breastfeeding important to you? And do you want to just try to give this baby the colostrum that we can hand express? Baby wasn't peeing, wasn't pooping. So those are all our measures that the baby is doing well. So we chatted and we talked about, if we give formula, does that undermine the success of breastfeeding? And what does she want to do? So we used a supplemental nursing system, and I'm thinking, oh, I'm going to be in trouble for giving formula here. But it was a joint discussion between the patient and the dad and the mom, and we used the system that the baby was getting breast milk, breastfeeding with formula at the breast. And the baby nursed. And she was doing well. The dad was
So she was getting formula from a bottle.
Yeah, it's a contraption that we use
whatever.
in nursing.
Look,
With
it's
a
been a
little
while. Don't
tube.
laugh at me.
Kind of hard to imagine,
I'm
but
not gonna-
but it works. And this baby was breastfeeding, and you know, by herself. When we had the lactation consultant come in and give her a plan that she would do this for like the first day, and then maybe drop down to every other feeding, and then just solely breastfeeding. And she was doing it on her own. You know, she was making up her own plan. She would try to get the baby on nursing. But it was that little bit of something that helped that baby sort of wake up and nurse. And I still sent her home thinking, oh, did I undermine that success of breastfeeding by instituting this, or is she going to be okay? And it was so nice to come to work and get a little note from the patient to say, I just want to let you know that we're breastfeeding great, and the baby's pooping. Because that was the big issue.
The best news
peeing and
possible.
pooping and doing plenty of that.
Good.
So it was nice to include that patient in the plan, understand what her goals were, and then also to believe that she could do it and have control over it. And she did such a great job. It was truly satisfying.
Does it ever occur to you that in that kind of an occasion, when you're teaching mothers how things sometimes don't go in a straight line with babies. You're teaching them something far more profound than how to get a baby to move from formula to breast and so on and so forth. That I think particularly, first-time moms, and everything is a challenge, and everything is, am I doing it right? Or am I doing it wrong? Am I a failure at this? And so on. I sense from you telling the story, the woman felt like she had failed the baby in some way in that. So do you ever feel like you're doing something far more profound that, this could enter into a lot more stuff as the kid gets older?
And I see some of my postpartum nurse friends here as well. And I think that is really what we do. You may think that, on the face value of things, that we're just helping breastfeeding or we're taking vital signs to make sure that they're safe and not bleeding too much and, doing tasky things. But really, it's about being with them and helping them to feel more confident in their abilities. Helping them, we might first have to have more of a hands-on approach, but then step back. But then also pointing out and helping them see that they know their baby better than we do. See how that baby's just looking at you. That things aren't going to always go the way that you planned. That your pregnancy might not be the same, your labor and delivery might not be what you expected. Your kid might get sick when you're planning that big party, and, you have to kind of go with it and be flexible. But that they are the expert, that they know it. It's about giving them the tools to understand.
Hey, you had your children while you were working, did you not? And what did you learn from that about, in terms of how you practice? Were there lessons from that?
So I worked in OB for many years before I had my own children. And I think I learned to be a little bit more flexible, not so by the book.
I'm sure there are a lot of mothers out there who are grateful for your experience.
It is funny, as I say to people all the time who are in OB, or even my students, I don't know what to do because I've never had a baby. I say, well, you don't have to have, a surgery or medical to care for somebody. It doesn't matter. I said, maybe I think before, and I know many nurses that don't have children of their own and are great OB nurses. What it did for me is made me a little bit more flexible, that there might be more than one way of doing things.
Right.
I might have been more by the book, by the evidence before, and then now realizing that it is. So I think that maybe I did allow them to be that decision maker for their child, to see that, how things are. And also to look for the support. I often tell my patients all the time that when I had my kids, that I had the luxury of calling my good friend. Is this right? Am I feeding her right? Am I doing everything right?
Yes.
And they'll say, oh yeah, it's fine. She's gaining weight, she's doing fine. Quit worrying about things. A lot of our patients don't have that environment.
So what's striking about that is you were an experienced OBGYN nurse at the time, and you still had these uncertainties.
Yes.
That must be very helpful for people to hear when they're experiencing their uncertainty. It's natural.
It's natural. It's normal to feel uneasy about things.
Now, we're going to turn to questions from the room in a few minutes. Right, Tracy? Yeah? Tracy is my boss, I think. Tracy Bean and everybody who put this together. So thank you, Tracy. I imagine, Mimi, that you must, I know you're a teacher, you're a mentor, you're a leader. You must get a lot of nurses, young nurses, coming to talk to you with particular questions about the field. And what are the issues they're raising to you? I mean, using you as a mentor. What can I do? What should I do? What are the issues they're raising? What kind of advice are you giving them? What are the issues for these younger nurses who are coming into the field that you can help them with?
Who are coming into OB?
OB,
or into
yes,
nursing?
into OB.
Just to, of course, every new nurse has to learn the acronyms, right?
That's right.
They have to learn.
Take the book home and study it.
They have to learn the lingo, the acronyms. They have to learn, like, the task part of that. But I think I like to let them know that it's more about understanding why they're doing something and never settling for, okay, I'm comfortable now. They have to push beyond that. And I think that with A1 and a professional organization, helps you to have that lens to look at things. I work with people that have worked in the same institution for so many years, and this is the way that we do things. And as much as the institution loves you to stay with them all the time, sometimes it's good to work someplace else that you may, and of course I laugh about it when I lived up here in Boston and I had that forward-thinking nurse manager, went down to Connecticut to live and to work, and I was shocked that they weren't quite as advanced as we were. But of course I'm thinking
Well, that's the backwoods, Connecticut.
Of course it is. I'm coming from Boston.
Oh, God, Boston people.
And after I got off my high horse of this is not the way we do things in Boston, I could look to see that in that hospital they did some things that were very good and better than what we do here in Boston. And there's some things that we did up here that they could learn from. And so working with your professional organization, you get that broader view that yes, you understand what is the best care and how things work in one institution, but when you look globally at what is the standard of care, not just here in Boston, but throughout the country. What are the issues? It helps you to be more open, to be a better nurse, to look at it more as what the research and the studies say.
Did you learn things when you went to Haiti, for example?
Oh, certainly. Going to Haiti, and I went to Ethiopia with Save the Children as well. In different countries, they are not as fortunate as we are, certainly with resources and supplies, but also nursing. I think nursing is still back in the age where they're very task-oriented. So some of the work that I did there was professional development for nursing staff. And some people will say, oh, it's just, do you really make a difference? I felt like, yes, I was going there to help them and to teach them. This is evidence-based practice. These are things that we're doing. But what gave me the satisfaction and I felt like helped the nurses were that our group was there for the nurses, to empower them and enable them to feel important about the practice that they did, that we cared enough to come and to share best practices, to validate that, yes, it's difficult for them to be the only nurse for 20 patients. It would never happen in our country.
No.
There's shifts, there's care, but we need to look at what are some standards and what we can do for nursing to raise the level, because nursing makes a difference.
You told me a shift down there was what? What were the hours?
So because of their constraints, the shifts, here we either do 12-hour shifts, day, night, 8-hour shifts, but because in this hospital they have the day shift, which was 8 to 4 because of the bus system, but the night shift nurses started at 4 o'clock in the afternoon and they didn't get home until 8 because there was no other way to get back. So that is one long time to be up. So, so of course during the earthquake though, there was many people. I had been going down pre-earthquake, but at the earthquake there was many American nurses and physician teams going down and seeing these nurses and seeing that they're like sleeping in the back room.
Which you would never do here. You'd be fired, right?
Yeah, we would be fired if we were sleeping at work. And they were saying, the nurses down there. Well, let's look at, is that reasonable to have a shift that long without a nap period? The key, though, that they didn't quite get, though, is that you had to, shift. You sleep now, then I'll sleep.
Sure.
So it's just a little fine-tuning there. And in fact, there's some data for us to look at to say if nurses take a little nap, a rest period, that they're going to be more productive. So that we have to kind of look at that and learn from them and, help them as well. But it is very, very different. There's challenges. I had my last trip down to Haiti was after the earthquake when they got so many supplies and equipment. So they wanted us to come down and teach fetal monitoring. So I said, okay. I was a little hesitant because my experience in Haiti is they had no paper. And in this country, fetal monitoring hasn't, and it's a good tool to help you screen and to identify, but it really doesn't change the outcomes. And I couldn't see that it was going to help considerably, but that's what they asked for, and I went down. They had a donation of 5 beautiful monitors, same equipment we use at Mass General. Beautiful, beautiful. One of them had its plug. The rest of them, we searched to find plugs. You had this beautiful equipment, but the
No place
nurses didn't know how to use it, didn't know how to integrate it into their practice, what was the benefit, and, did we think that it was that beneficial for somebody to be hooked up to a monitor all the time like us?
Right.
Certainly not. So using the equipment that's there and helping them to understand is important work for us to do. And I think together, nursing groups and consistency keep going down and help support. Yes, we threw a lot of money and a lot of help after the earthquake, but we can't just let them be. We have to go down and support them and help build that practice as well.